glad to see all of the people in the audience today. Welcome to the Cigarette Restitution Fund Lunch Learn Link seminar. Today's lecture with Ravi Varadhan is co-sponsored by the Cancer Outcomes and Health Services Research Group, which is a subset of the Cancer Prevention and Control Program members for the Sidney Kimmel Comprehensive Cancer Center. We're bridging a lot of Johns Hopkins today. Ravi himself is a member of the Cancer Center, a participant in the Cancer Biostatistics Core at the Cancer Center, and a member of the faculty in biostatistics at the Johns Hopkins School of Public Health. And I was just telling him I read one of his articles, which is very philosophical, but I think what it indicates to me is he is a real thinker about issues such as frailty and aging, and he can put that thinking to effect in his skills as a biostatistician. So, Ravi, I'm very excited to hear your seminar today, and we welcome you.
Yes. Thank you, Norma. Can you hear me?
All's good.
Okay, and you can see the screen as well?
We can.
Okay.
You want to put it on the full screen?
Yep.
Yes, perfect.
Great. So yeah, thank you for the opportunity and also for the kind introduction. So I'm going to be talking about a number of things, especially ideas from aging, how our understanding of how to measure aging has advanced over the last several decades. And at the end, I would try to point out how this understanding could potentially be useful in treating, managing cancer patients. So this is my outline. First, I want to address the aspect of measurement of aging, because in science, we always want to be able to quantify the concepts that we use. So here the concept is aging, and so it's very critical that we have some ideas on how to measure aging. And this can be done at two levels, and I'll talk about this at the population level and at the individual level, and they're both useful. So at the population level, we know that the life table methods, that the census, U.S. Census puts out, the actuaries use these widely, starting with Gompertz in the 19th century. So people know how to measure aging at the population level reasonably well. But at the individual level, it's a little bit more challenging. It's because of the heterogeneity of the aging process. So people of a given age, a chronological age, are not the same in terms of how fit they are physically, cognitively. So that's why this idea of biological age came about. So we want to quantify aging at the individual level, because that's what is relevant for the clinical management of patients. And then I will talk about more recent concepts that have emerged in geriatrics and gerontology, which are frailty and resilience. Frailty has been around for a few decades now, but resilience is a relatively new concept in geriatrics, although it's been well known in psychology and other fields. And in fact, you could even say that all of philosophy, spirituality, everything pretty much deals with how to make a person resilient, because we cannot control our external circumstances, but how do we handle the challenges, that we are exposed to from the external world? So that's the idea of resilience. And so now we are beginning to study the biology of resilience. So I will talk very briefly about this. In particular, I will mention a study that we have been funded recently by the NIA to look at resilience of older adults who are undergoing various clinical procedures. So as I said, finally, I will try to bring these ideas to focus on how they can help in the care of older adults with cancer. So here in the last bullet point, I'm not planning to do a very comprehensive review. There are probably many aspects where aging concepts can be helpful, but I'll just touch upon a few things that I am familiar with. Okay, so I'll start with a statement by Peter Medawar, who is a Nobel laureate who got Nobel Prize in immunology for some of the work he did on graft rejections and things like that. But he wrote a very nice essay on aging. He called it the unsolved problem in biology. Where aging is the unsolved problem, and I think to a large part it is still unsolved. There are a lot of theories, a lot of good ideas, and we know a lot more about aging, but we still haven't gotten to the crux of aging, I think. So it is still very much an unsolved problem. So Peter Medawar mentioned that, in English, we don't have a word that captures aging, because, what he means by that is mere passage of time is what we might call aging, but he wants to separate that mere passage of time from actual aging, which is the deterioration and the decay and the decline of functions and things like that. So he says there is no word for that. And he says he is going to use the word senescence, although these days people use senescence in a more specific way with regards to some cellular processes. But at the whole person level, there's really no word for aging, which separates it from chronological aging, right? So you may call it biological aging or whatever. So then he also said, he talked about how do you measure this aging process, right?
Hi, calling Laurie Davis, please.
Hello.
Hi, this is Joanne. I'm one of the nurses that work with Dr. Stone. 1 minute, please. I'm gonna minimize this. I'm on a lecture bag. I wanted to call you. Was waiting for
your
the
mic off.
And
I think someone is talking. Sorry.
That's how embarrassing. Anyway, I apologize. You will receive a call from interventional radiology.
When Nugent, your microphone.
Is there a way to mute people? Okay.
Thank you. Thank you so much.
Okay, thank you. So I was talking about, Medawar also talked about two different ways to measure senescence, what he called senescence. So he said first is personal. For example, things like, rate of wound healing or acuity of the senses and things like that. The second one is at the population level, what he calls statistical. I think I mentioned this before. So here, when you look at the, something like this, right? This is a classical hazard curve, right? The hazard of mortality. So on the y-axis, on the log scale, you have the hazard of mortality. And on the x-axis, you have chronological age, right? Here, there are two ways in which you can look at these curves. One is called a period hazard curve, and the other hazard of mortality. And the other one is a cohort hazard of mortality. So in the period curves, what you do is you take a particular time, 1915 here, and then you look at people that die at different ages. right? At a given year, you look at people that died at different ages and you calculate the probability and the hazard of death at different age intervals. So you get this period curve, like the red curve. But in the cohort hazard curve, you follow cohorts that are born in the same year, and then you follow them through until the cohort becomes extinct, right? So you get slightly different ways, in which these hazard curves show up, right? But the point here is that the hazard typically declines very sharply from birth until a period around 10 to 12 years, around puberty roughly, right? That's when the hazard is minimal. Then it stays relatively flat, depending on which curve you look at it. If you look at the cohort curves, it generally tends to be flat. Although you see this quadratic hump here around 20, 25 years, those are generally attributable to some young age related high risk activities, such as wars or other kinds of things like maybe accidents. But in general, if you could eliminate such hazards of mortality, you can hypothesize that the hazard curve would be relatively flat between 10 to 30 or 35 years of age. And then it starts to increase log linearly after 35 or 40. So you could roughly say that aging begins around 30 or 35, right? And then you have a nice linear increase afterwards. So it's sort of a population level way of looking at it, right? But of course, this may or may not apply to the individual level. As I said, there's a lot of heterogeneity at the individual level, right? So now at the individual level, what do we mean by an older adult? But if you look at any study of aging in geriatrics and gerontology, it's almost universal that the definition is older than 65 years of age. That's the definition of old age or older adult, right? So you could use proportion of adults older than 65 years of age as a metric for the aging of the population, right? But Norman Ryder, who's a well-known demographer, in 1975 made a very interesting comment. He said that to the extent that our concern with age is what it signifies about the degree of deterioration, it would be more sensible to consider a measurement of age, not in terms of years elapsed since birth, but rather in terms of number of years remaining until death. So he wants the clock to go backwards, right? Mm-hmm. So from death, working backwards, right? So he says you would be old if you're less than 10 years away from your death, for example, right? So he says we propose that some arbitrary length of time, such as 10 years, be selected, and that we determine at what age the expectation of life is 10 years, right? So there are a number of advantages to using something like this for policymakers and things like that, right? So suppose if you want to rejig the Medicare, maybe you can use this metric and say Medicare should really begin at 77 or 75, not at 65. Because in the old days, maybe, the majority of the population had less than 10 years to live at 65. But now more than 50% of the population lives past 75. So maybe the policy has to keep pace with such changes, demographic shifts, right? So he proposed that, and then I want to point out that this idea also has utility for cancer screening. I will discuss that at the end, right? Okay, so now I'll talk about some measures of biological age that are well known in aging field. And so I want to start with this guy. He's a Dutch man, right? Of course, I don't think anybody would know this guy, and there's probably no reason. But he's very interesting for the fact that he's 69 years old. Of course, when you look at this picture, you probably wouldn't be able to tell that he's 69, right? he petitioned to the court, and he wanted to change his age legally to 49. And he gave some crazy reasons, like he wants to find more dates on online dating services and things like that, right? But then, how did he come up with his age, right? So that he probably went to something like this, right? There's a website called Inner Age 2.0, right? This is actually not like a quacky website, right? At first I thought, oh, this must be some crazy website. But then it's actually associated with some people from Harvard. This guy, David Sinclair, who's a well-known researcher in aging. I think he's involved with this Inner Age 2.0 because I happened to listen to one of his seminars on YouTube a couple of weeks back. It's called The Art of Aging Well. It was one of the famous seminar series put out by Harvard. He actually mentioned this. It was really kind of a corny thing. He says he has this treatment, right, based on sirtuin pathways, some red wine and some other sort of things. And he says he took his treatment and he looked at his inner age before and after he took his treatment, and he showed some curves. His inner age was some 49 or something before he took the treatment, and after he took it, he went down to 34 or 33. I said that was like crazy, But anyway, I mean, these are people from Harvard, right? So this Inner Age 2.0, it has a list of biomarkers here. For males, there's a different set of biomarkers, and for females, it's a different set. So it's like albumin, DHEA, different hormones, glucose, lymphocytes. So it has the immune systems, and then it has metabolic things like triglycerides. So you put all of these together, and then there's a weighted regression calculation that you apply to this, and then you come up with your inner age, right? So this is one of the more recent versions, right? But this started way back in the 1950s. John Hollingsworth, he was at Cornell, I think. He undertook this study of people who were in the Hiroshima region, right? They were affected, obviously, by the atomic bomb in the 40s. And so this study happened in the 50s, and he was doing a number of tests to quantify the physiological age. Their hypothesis was that the atomic bomb catastrophe must have, accelerated the aging of these people. So he used a number of measures, which make a lot more sense to me than the inner age calculator, right? So things like hair graying score, skin elasticity, systolic and diastolic blood pressures, grip strength, and so a lot of these measures are very sensible, actually. And he came up with a way to combine all of these into, in a regression model and come up with a biological age measurement. So then Alex Comfort, who's more well-known, he's a British gerontologist. He also came up with a test battery to measure aging, right? And his battery used, sorry, I don't have the measures in his battery, but it's probably somewhat similar to what Hollingsworth did. And then more recently, in 2001, there was a nice paper in Journal of Gerontology where Eugene Yates cataloged the rate of decline of various vital functions and different organ system measures, how they declined with age, right, between the ages of 30 and 70, which is a very important range actually to study aging. So if you actually want to understand aging, you have to study people before they actually manifest aging, which typically happens in the 60s and 70s. But you really have to start in the 30s because, as I showed before, I think it's a good hypothesis to say that the aging really starts somewhere in your 30s or mid 30s. And so they came up with an equation like this, right? For every single measure that they used, they fitted a linear regression model, right? Which is the rate of decline here, K, and 30 is the age at which they anchored the aging process to start. And so the decline is captured by this linear model, right? And then they catalog the values of K, the K sub S, which is the rate of decline per year, right? And X is your actual age, rounded to the nearest year. So they went through, from various studies. This was not actually a prospective study. They retrospectively collected data from a number of cohort studies and they cataloged it. And they saw that the linear loss rate for many systems, physiological systems, was around 0.3 to 1. Average was around 0.5, 0.6. Right. So you could say roughly that the rate of decline is about 0.5% or maximum of 1.2% per year, right? That's about the average rate of decline according to their estimation. But now more modern versions, of course, if you go back to this, they don't talk about, they try to select normal healthy populations as much as possible. But you can imagine that if people have some diseases or comorbid conditions or things like that, the loss rate might vary considerably from this average rate. And now, in more recent years, in the past 6-7 years or so, there are more sophisticated versions of biological clocks, right? So here, for example, they collect tissues from different body organs, and then they look at the epigenetic modulations. The DNA methylation age, for example, is a very well-known marker here. But these modern measures of aging are essentially based on one or more of these hallmarks of aging. There was a nice paper in 2013 by Carlos Lopez Otin, who sort of described these 8 or 9 fundamental processes which he hypothesized as underlying aging. So things like epigenetic alterations, telomeres, genomic instability, mitochondrial dysfunction, and cellular senescence, and things like that. So these are all key factors that promote aging. And so the modern measures of aging try to measure one or more of these markers of aging. So this DNA methylation by Steve Horvath is a very popular aging clock, right? So this he used multiple tissues to come up with this epigenetic clock, and he showed that it has some nice properties, like it is close to 0 for stem cells or pluripotent stem cells, and it correlates with the cell turnovers and things like that. And he also looked at in some cancer tissues and things like that. I don't know, I don't understand the biology of this. So, but I know that this is popular and a lot of people are beginning to incorporate measures like this in longitudinal studies of aging. And then another one is transcriptome-based aging. So it's not DNA methylation now, but it's a transcriptome, like how the genetic code is transcribed. And so here they have a measure called bit age. It's a binarized transcriptome age, and they show here that it's pretty accurate in measuring the age in C. elegans, where there is no methylation. So this idea can be used in those species, but also they show that it can also work in humans. So that's how the field is heading in terms of the measurement of biological age. One major limitation of all these studies is that pretty much most of this data comes from cross-sectional studies. They collect people of different ages from 30 to 70 or 30 to 90, and then they measure these things. They don't follow individuals longitudinally. So it would be really nice to actually see how the epigenetic clock, for example, changes individual as they age. But such data is very difficult to come by. Probably the only cohort that might have that, to my knowledge, might be the BLSA, the Baltimore Longitudinal Study of Aging, which was founded by Nathan Schock in the 1950s, because he had this foresight that to really understand human aging, you need a longitudinal cohort where all these processes have to be actually measured as people age. You cannot cobble together a bunch of people of different ages and try to understand aging. It can give you a distorted picture. So that's something that I want to point out. And then different way of looking at biological aging is not probing deeply at the cellular level, but looking at it at the whole person level, like the physical function, the cognitive function of people, and trying to quantify this idea called frailty, which we define, our group at Hopkins, originally led by Linda Fried, who was also, professor in epidemiology, I think. So Linda was one of the first ones to really think rigorously about how to measure frailty, and she came up with these five symptoms. I will describe that briefly after a couple of slides. But I think the idea of frailty is that individuals of the same age may have chronological age may have different underlying vulnerability to stressors. So if you perturb the individual, whether they're undergoing a clinical procedure or they're taking a new medication, or whatever sort of perturbation that you can imagine, right? How vulnerable are individuals to these perturbations, right? That's what we call as frailty. How frail or how fragile a person is to external perturbations, right? And one of the original ideas was by Ken Rockwood, where he quantified frailty as just accumulation of bad things, accumulation of deficits. As a person ages and as a person becomes frail, they accumulate more stuff, more bad things. He says that you don't necessarily have to specify the kind of things that accumulate. You can take any system as long as there is some variety, and you can accumulate enough things, you measure enough things, you can quantify this thing called frailty. So if you measured, let's say 30 things, so how many systems are dysregulated out of the 30 things you measure? So hoping that there is a cut point for each measure, you can say whether that measure is dysregulated or not. And you quantify, you count the number of deficits. And so in the numerator, you have number of deficits, and in the denominator, you have the total number of systems you measured. So if it's like 10 out of 30, then your frailty index is 1/3 or 0.33, right? And so he generally said anything about 20% is frail, right? And he also showed that this frailty index is a very powerful predictor of all kinds of things, including mortality, right? So this idea is called deficit accumulation index of frailty. So there's no specificity to what is wrong with an organism. It doesn't matter what's wrong. As long as there are a number of things that are wrong, that system is frail. So here, for example, a major list of things that you might ask an older person in a geriatric assessment, right? Do you need help bathing, dressing, eating? things like that, and then you can also measure their performance, like walking, grip strength, then spirometry measures, and then you ask them about their diseases and some psychological assessments. So you can put it all together and you can come up with a deficit index for that person, right? So then, but Linda Fried's approach is a little bit different. She actually wanted to make it more specific, so she said, okay, I want to look at how well a person walks. What is their gait look like? How active they are, their physical activity, and how fatigued they get during their regular chores and things like that, and how strong is their upper body strength, or it could be lower body strength as well. But Linda uses upper body strength, the grip strength, and then unintentional weight loss, right? So it's a very common thing in cancer patients. It's unintentional weight loss. So you put these 5 criteria together, and if you have 3 or more of these manifestations present, then you're deemed to be frail. If you have 1 or 2, it's called pre-frail state, and then you have no deficits, none of these 5, then you're considered to be robust or non-frail. So then these frailty indices are pretty good predictors of mortality. In fact, they're among the best predictors of mortality, that you can find. So the only things that I've seen that come even close to this are probably similar measures, like in cancer literature, there's Karnofsky scores, they're pretty good at predicting mortality. And then you have self-rated health, or measures from SF36, there's a self-rated health component there. They're also very good predictors of mortality. But these frailty indices are probably among the best predictors of mortality. Now I'll talk about resilience. As I said, it's a well-known idea in psychology. So resilience is typically associated with the psychological domain, right? How do you face adverse challenges? How do you face adverse conditions and challenges? And how do you cope with them? That's sort of the idea of resilience. But in clinical terms now, we call it physical resilience, just to separate it from psychological resilience. Is the notion of how well your physiology recovers from a major stressor, such as chemotherapy or bone marrow transplant or total knee replacement. And these are major procedures that older adults undergo, right? And so in about 4 or 5 years ago, there was a workshop organized by the NIA to come up with measures of physiological resilience. And that's sort of, they also came up with the research agenda for how to study resilience in older patients. And so I was part of that, and I wrote also a paper on this after a year later, where I kind of pointed out that this is essentially a concept that has a dynamicism to it. I call it dynamical systems idea, because you're actually perturbing the system, right, and monitoring the response, how the system responds. So you have to actually measure the dynamics of the whole system, including the magnitude of the stressor. And also you have to specify what systems you are studying. For example, you can look at autonomic nervous system, or you can look at the immune function, the inflammatory markers, how they respond. So you have to specify what systems you're going to study and quantify the perturbation and the recovery. So there are 2 phases. When the system is hit with the stressor, it's going to respond, and it's going to take a beating initially, but then that's the adaptation part, and then it recovers back to baseline once the impact of the stressor wanes, right? So these curves kind of show the idea of what I'm talking about, right? So here, the stressor is bone marrow transplantation. It happens at time 0. So we have measures at baseline, which is before they undergo bone marrow transplant. And here's platelets. We look at platelets, hemoglobin, and a variety of other biomarkers, right? We look at the baseline, and then once the stressor hits, the values of the marker drops significantly, and the nadir, or the minimum, is reached around 2 weeks on average, right? I'm not showing the individual curves, it's sort of group averages here. There's a lot of noise in individual curves, as you would expect, but the averages show nice patterns. And then the platelet recovers right after the minimum around 2 weeks. And so it could be very interesting to see for individuals how quickly they recover, right? So you can look at the magnitude of the dip, right? From the baseline to the minimum, what is the magnitude of the dip? Like how sensitive is the system? That could be one measure. And the other one is how quickly they recover to baseline, the rate of recovery. And in some cases, they probably don't recover all the way to baseline. There may be a deficit, right? So you can quantify a number of dynamic parameters and then potentially use that as a prognostic measure of how well people would do in the long run, right? So in fact, we are working on developing such metrics, like the recovery parameters and the prediction of overall survival at 1 year or 2 years or things like that. And here we are showing the impact of aging. As you can imagine, the older adults, show more of an impact. Their recovery is slower compared to the younger adults. And these are other markers, lymphocytes and albumin. Albumin shows a lot of age-related differences, actually. So, and in fact, in our models, the models that we have so far for prognostic, for overall survival, the levels of albumin at 8 weeks, seem to be pretty strong predictors of survival after 1 year or beyond 1 year. So we are looking into this more closely. And so this idea of resilience, as I mentioned, we have a conceptual model. We have a study that's funded by the NIA. This study is called SPRING. Jeremy Walston, who's a geriatrician, Karen Bandine-Roach, biostatistician, and myself, we are the PIs of the study. So we look at, characterizing the dynamic response of people to 3 different clinical stressors. And these studies are called Restore, Rebound, and Ready. The Restore study looks at older adults undergoing total knee replacement, how well they recover from knee replacement. And Rebound looks at bone marrow transplant people, older adults. In Rebound, the criteria is 60 and older, whereas in Restore, it's 65 and older. And in Ready, which is people undergoing dialysis, this has a more, a larger proportion of African-American patients here, whereas the other 2 have much smaller representation of African-Americans. So here the patients undergo dialysis, hemodialysis. So these are the 3 stressors that we are studying. And our model is like this. So here in the black box here is what we call reserve or capacity, right? Your intrinsic capacity, which is your level of fitness or vitality, whatever you want to call it, or you could call it measure of biological age, And what are the determinants of this, right? The predeterminants are things like your chronological age, your psychosocial factors, the health behaviors, comorbid conditions, and your genetics. All these things go into this determining your intrinsic capacity, right? And this is what you draw upon when you are challenged by a stressor, right? So how you respond to the stressor depends on your intrinsic capacity or your physiologic reserve. So how much gas you have in the tank, sort of idea, right? If your stressor is of such a magnitude that it exceeds your intrinsic capacity, then you would die, or you would have a irreversible response to the stressor. You won't be able to recover. You would be handicapped for the rest of your life, or some major impact would be there. But if you have enough reserves to address the stressor, then you can bounce back. And even if you don't get back to baseline, but you can still maintain your identity in terms of physical and cognitive function, right? You probably have to cope a little bit. Maybe you use something like a walking aid, or a cane or something like that, but it won't completely change your lifestyle dramatically. So that's the idea of resilience, right? And of course, eventually you care about the clinical outcomes, right? In the case of bone marrow transplant, the outcomes that we care about are relapse and overall survival. Those are the things we care about here. And also some things like graft versus host disease, which is a major immune system reaction to the transplant. So these are the things that would come under outcomes. And for physiologic stress response, you have to monitor a number of systems, autonomic nervous system through EKG monitoring, immune system measuring inflammatory markers, things like that. Whatever are the major stress response systems, you should be able to monitor them. So that's the idea of physical resilience, which we are collecting data now. The study is now 3 years old, and we are in the penultimate year of the study, and so hopefully we'll have a lot of data to look at this idea of resilience. So now I don't know how much time I have, probably not much, but I will try to finish up, how gerontology can benefit oncology, right? So there are numerous concepts and ideas I've already mentioned, like biological aging, methylation aging, frailty, resilience, reserve capacity, things like that. So as you can see, there is no optimal way to quantify aging process. There's a lot of dialogue that is ongoing. It's a very dynamic field, a lot of debate. So we still don't have a clear idea of what are the most fundamental aging processes. There are a number of candidates, but the relative importance of these processes are not well understood. And of course, we know that cancer is predominantly a disease of aging. So there has to be a strong connection between aging and cancer, so the question is, how can we make use of the ideas from gerontology, to help with our care of older adults in oncology? So it depends on the context and the goal, what question we want to answer. So I will just mention some problems here, right? So here's a paper that uses the idea of geriatric assessment. Like I showed you the Rockwood table, there were a number of assessments that was there in Rockwood's deficit accumulation. So you could use something like that, right? So Eileen Browner, for example, is probably, the only person that I know of who does all these geriatric assessments in cancer patients. So she looks at these assessments to look at whether the person can, they are fit enough to receive intensive chemotherapy, right? If they're not, then maybe there's a milder version of chemotherapy that needs to be administered to these people because they're not resilient enough to handle intense chemotherapy. But here they show that the geriatric assessment, if you don't make use of this, right? In other words, the geriatric assessment result does not influence your treatment decision. You just treat people according to the standard paradigm, right? So here they show that the geriatric assessment predicts survival of older adults, you know, who are undergoing induction chemotherapy. But I really feel like, you know, there's a lot of work that can be done, you know, in terms of all these aging measures like frailty measure or biological age as an effect modifier, you know, like how it modifies the effect of treatments. In other words, if you make your cancer treatment decisions based on a person's underlying physiological age, you know, does that actually have an impact? So that's a very interesting question. I think there's very little that's done in that area. So here it's a study where R.D. Huria, who was one of the leading geriatric oncologists, she passed away a couple of years ago, but she did this study where she studied resilience in older women receiving breast cancer. So she defined resilience as returning to within 10 points of baseline, where the baseline function was measured using this Euroqual measurement questionnaire, right? And then there are papers that look at, this is what I was talking about, individualized treatment decisions for older adults. So this is more of a concept paper, but this has not been implemented in practice, but I think it'll be interesting to do a study on this. And then the area that I'm quite interested in is actually how to make screening decisions in older people with limited life expectancy. So here, Louise Walter, who's probably the foremost leader in this area, she showed that, you know, prostate cancer screening is done in older people without taking into consideration their life expectancy. So she showed that the screening rates exceeded 60% for some subgroups of men with poor health. So this is the idea that Norman Ryder that I was talking about, right? So these are really old people, you know, not chronological old, but physiologically old. So their remaining life expectancy is less than 10 years. So why would you want to subject them to potentially risky interventions with limited benefit or you know, uncertain benefits, right? So our own Nancy Schonborn has done a lot of studies in this area too, like focus groups and things like that. And she also showed that you know, there's a lot of older adults are still frequently screened for breast, colorectal, and prostate cancer with limited life expectancy, right? But the problem is that, you know, while this is a good idea, but when you mention to physicians, they'll say, but I don't want to prognosticate their life expectancy. I don't have a good way of saying whether someone has a limited life expectancy or not, right? That's the challenge. So we wrote a very recent paper that was just published last month or a couple of months ago, where we looked at life expectancy estimates based on comorbidities and frailty to inform such decisions, right? This is based on SEER Medicare data. So it's a pretty large population, more than 250,000 people from the SEER Medicare control group. So we came up with a table like this, where we have life expectancy by years of age, chronological age, by sex, male or female, by Charlson comorbidity, you know, low, no comorbidity, low or high, and then frailty, low frailty or high frailty. And then we showed that if you have high frailty with high comorbidity, pretty much at all age groups, you know, your remaining life expectancy is very low, is below 10 years. So by Norman Ryder's definition, you're old. So then you have to really think about administering intense treatments in these groups of patients, right? But as you go to no comorbidities, unless you have high frailties, if you have high frailty, even in this group, the life expectancy is pretty low. So it's kind of very interesting. So what we showed was it is not sufficient just to consider only comorbidities. You also have to consider person's frailty status in order to come up with a more accurate assessment of life expectancy. And so I think this something like this could be useful as physicians are considering, major treatment decisions in older adults with limited life expectancies. So with that, I'll conclude my talk, and I can answer any questions or comments.
Thank you so much, Ravi. It's certainly a lot to think about. So you did bring it home to what it is that we could do in the cancer world with the concept of frailty. Do you think the prospects are good for measuring it on a regular basis in, just among patients? I mean, so that, it could guide screening, it could guide treatment and so forth.
Yeah, it's a great question. So one of the major comments we had from the editor as well as the reviewers when this last paper that I just mentioned was, how can this be translated into clinical practice? Like, would a busy oncologist or whoever will have time to actually assess frailty in a clinical setting? And so, of course, I mean, if you show that it is very important, then where there is a will, there is a way. If there is a way for us to bill for this this additional time, or things like that, that's one way. Or you could have like what Eileen Browner does, right? Like have a geriatric screen consult for oncology patients, so that there is a geriatric assessment that is done separately, and then the decisions are made based on Eileen or their sort of assessment, right? So it's probably possible to do that. Another alternative is that maybe there are some cheap and dirty frailty assessment tools, right? Which don't require a lot of time, which can be done by just a scan of your medical records and things like that.
Yes.
Right.
Yes.
Yeah.
Well, I would work a good bit with talking about participation in clinical trials. And often, and our goal is to offer trials to eligible patients always. Yeah. And by anecdote, we know that the decision to ask and discuss clinical trials gets made based on just an observation. So a person comes in on oxygen or in a wheelchair, they are not approached for a clinical trial. And, I don't even know for sure whether they were eligible or not, but by their disease category, they were. So, it would be great to make it more explicit how we make our decisions.
Yeah, yeah. That's actually interesting, right? In the old days, like you would see clinical trials, one of the exclusion criteria would be frail older adults were excluded.
Yes. Yeah.
But there was no definition of how do you know they're frail? So there was no specific definition of frailty. And this was actually one of the initial incentives, like when Ken Rockwood and people like that were working on this idea of frailty, they wanted to make it more explicit, So Elizabeth was asking a question,
I'm sorry, I have to run. I have to go run a retreat, but this I think is really important. So Ravi, you do both of these things. You are a researcher who focuses on aging, and you are a researcher who focuses on cancer. The key is, how do we actually continue to bring people together, like we've been trying to do, to maintain this infrastructure going forward, to address the really important questions? Like you raised the issue of measurement, right? Measurement for research, in the cancer space and measurement of aging for the provision of care to people at risk for cancer and with cancer for treatment and long-term survivorship. So I just wanted to put that on the table, but I have to run because I have to go run a retreat.
Okay, thank you.
But thank you, Ravi.
Elizabeth.
Thanks, Norma. Bye.
Bye-bye.
Yeah. No, I mean, this is what, Elizabeth has this working group that we were all part of, cancer and aging, trying to sort of interface. It's exactly, I mean, my talk was motivated by, participation in her working group, last year. So I think this is a very interesting area for, I think that there can also be some, this is something I haven't thought about, but I also want to think about how cancer can benefit aging researchers,
Mhm.
I've sort of thought about it unidirectionally, right? How the ideas from aging can help cancer patients. But then I think there's a lot of cancer biology work and things like that that's going on that could potentially be very helpful for understanding aging biology,
Mhm.
Yeah.
Yes.
Question. I am one of the co-leaders for the Cancer Outcomes and Health Services Research Group. So thank you so much for a great talk. I work as a primary care doctor. So often, patients, try to get me involved in their decisions about cancer treatment, but often, that ends up being a decision with their oncologist, and maybe these factors about, their resilience or frailty do or do not get incorporated. So I often see these patients in the back end, they've already been treated for cancer and all the treatment effects that happen with that, right? And in my older adults. And so I guess my question is, has there been any thought? I think step one is like, how do we measure this in a clinical fashion? Easy, like it's a button and Epic and it calculates it for you or something like that. But I think secondly, how have you thought about like, if we're able to achieve that, how that might impact the way we manage our patients, right? After they've this stuff, if they're chemo or what.
Yes. So your question, if I understand correctly, is about measuring the aging process. Maybe you think of it accelerated aging or something as a consequence of all the beating that they have taken, the chemotherapies and radiation, whatever that they had to undergo. How does it impact their aging process, and quality of life and things like that? Is there a simple way to assess this rate of aging? Maybe even longitudinally, right? Like your patients come to you maybe once a year or something. Like I go for my annual checkup. Something like this inner age 2.0.
Yeah, but also like
you draw their blood and you send it out, and then.
Yeah, but maybe if we also knew like whatever this score is was like really bad, high or low, which way we want to measure that. Maybe it would be interesting to think, gosh, if they have a bad score, we should have PT, OT, whatever, X number of resources, like as a protocol, right? And I don't know if that's been thought of as if you hit a certain marker, here are the interventions we could or should have in place as a consequence of that.
Yeah, sure. That's a very important area, I think. I'm not sure, we obviously we don't know much about this. So but I think, there's some combination, right? I don't trust just biomarkers, whether it's methylation markers or, just blood-based markers. I don't trust them as just, accurate measurement of your aging. They have value, they have information content, but that's not the end all, right? And so if you go to the whole person level, things like gait speed, grip strength, I trust them much more than the biological markers. But probably a good approach might be to really think about how to combine these different multi-scale measures, right? The biological markers at the methylation level, the blood markers like glucose, LDL cholesterol, vitamin D and things like that. And then also your gait speed and grip strength and your cognitive function. Can we put it all together and, kind of look at the whole person, right? So this would be something very interesting. But then again, you want to make it feasible as well, something that should be feasible to the extent possible that you can piggyback on routinely collected measures. It's good. And if you want to introduce new measures, then you really have to show that there is a real value for them, you know?
Mhm.
That's where the challenge always is. I mean, you know, the translation from showing statistical predictive power to can I actually do it in clinic, you know?
Yes. Well, thank you so much, Ravi, for your talk today. It really did generate a lot of thinking among us, and of course, wanting to apply it. But we should have you come back and talk more about these issues. I mean, as an epidemiologist, for example, I'm just very curious about frailty as a measure in addition to physical age, because age is the major risk factor for cancer, and what happens in that dynamic. But anyway, I have an idea for bringing you back. So
thank you. Hopefully, when we have data from our study,
yes,
the
that
resilience
would
study.
be terrific. But thanks so much for your
Yeah.
talk.
Okay.
today.
Thank you. Thank you, Norma. Thank you all
Bye.
for having me.